So again, thank you for joining us today for our speaker meeting as the expert about tardive dyskinesia. I was sharing that the first week of May is recognized as Tardive Dyskinesia Awareness Week, and that there are approximately 600,000 individuals living with tardive dyskinesia, and 70% of those haven't been properly diagnosed. And with that, I want to introduce our expert, our amazing expert. We're so lucky to have him, Dr. Durand. He's the Vice Chair of Clinical Services at the Department of Psychiatry and Behavioral Science at the University of Miami, and the Chief Medical Officer from Jackson Behavioral Health Hospital. So thank you, Dr. Durand. I know how busy your schedule is, and you so willingly, as soon as we asked, you said, yes, when, tell me. We appreciate it. We can't do any of the work that we do without experts like you that support us. Don't even ask questions, just jump in. We are very grateful to have you. And with that, I'll leave you with our expert for tonight. Thank you for being here.
Well, thank you, Rosa, for the introduction. I'm really honored to be here and to provide a little outlook of what tardive dyskinesia is. If you don't mind, I will share my screen.
Of course.
Okay, well, again, thank you for being here. So let's talk a little bit about what tardive dyskinesia is, and I'm going to provide just a general outlook of that. I have the agenda here. Primarily, we're going to go through definition, then epidemiology, risk factors, how we assess for tardive dyskinesia, treatment, and then prevention. And as you, Rosa said earlier, this is a condition that it happens in a lot of patients who use antipsychotics, and in less degree, patients who use chronically antiemetics, like, these are medications for nausea and vomiting. They are very similar to antipsychotics, and some of them in the chemical structure, and they can potentially also cause tardive dyskinesia. So very, very plain definition here is tardive dyskinesia is a movement disorder, which is primarily characterized by involuntary movements of the face, the trunk, and the extremities. It can rarely affect the respiratory muscles, and it's a very difficult situation for some of the patients when they actually have that type of dyskinetic movements on the respiratory system, because they can choke, they can aspirate. Now, in terms of the characteristics of tardive dyskinesia, these are involuntary movements which are repetitive, are irregular in nature, and they're jerking type in some cases. In other cases, could be choreic type. And as I mentioned earlier, they can affect primarily the face, the trunk, and then extremities is not that common. Face and trunk, I would say, is more than 50% of the cases, and rarely the respiratory system. Now, when it affects the face, you can see blinking, like patients have this involuntary blinking. They can have also tongue protrusion or lip smacking. That is very characteristic of patients with tardive dyskinesia. When it affects the trunk and the limbs, you can see the patients can have like a shoulder shrugging, like they can do this. Some of them can have rocky torso movements, that they can move like that. And they can also have twisted finger movements, like type of choreatetotic movements. Also, you can see dystonic movements in tardive dyskinesia. Torticollis is one of the most common ones. When you see that, it's primarily the involuntary sort of tension and kind of dystonic movement of the neck, and could be very painful. And they also, when they walk, in severe cases, you can see the choreic or atetotic movement. It's like a dancing movement of the limbs. So they move the limbs in a dancing way, and it's involuntary. They cannot control it. So as you can see, with symptoms of tardive dyskinesia could actually be very disabling for patients. I have seen patients that the level of tardive dyskinesia is so severe that sometimes they cannot eat properly, they choke, they cannot speak properly, they cannot really do fine motor things, like fine motor skills are altered because of that. And it creates definitely a lot of dysfunction on them. In terms of epidemiology, as I mentioned earlier, antipsychotics increase the risk, even though the majority of cases of tardive dyskinesia are due to chronic use of antipsychotics. And there is a small number of cases that actually are due to other reasons, but the majority are described from patients who use primarily first generation antipsychotics, which are the all antipsychotics versus second generations. Second generation antipsychotics are less likely to cause tardive dyskinesia. However, the risk is less, but is still there. Unfortunately, most of the cases are non-reversible. You can ameliorate or decrease the severity and intensity of the dyskinetic movements with treatment, or sometimes by changing antipsychotic. However, total eradication of, or let's say total just eradication of the condition is extremely rare. It's extremely rare. Now, we talk about quality of life. Unfortunately, patients with tardive dyskinesia have a very poor quality of life because the movement could be very disabling. So they actually, a lot of these patients are very conscious of the movements, involuntary movements, and they don't want to go out and work, or they have major limitations to do even simple type of jobs. So it's definitely the quality of life is altered. A lot of them actually want to be in their house. They don't want to come out because they're very conscious of the movements, and they believe people will really observe them and will make fun of them. And it's really a situation where people really gets very, very, very affected. And then there is some literature that shows that increased mortality, as I mentioned earlier, particularly if it affects the respiratory system. Patients can be at risk of aspiration, and therefore to develop pneumonia. And also the fact that, a lot of these patients, when the tardive dyskinesia is moderate to severe, they cannot drive, for instance, or if they drive, they can go into a car accident. So they increase the rate of mortality by doing that. Now, in terms of risk factors, there are actually a lot of risk factors that are being linked to tardive dyskinesia. One of the most common ones is older age. So the older you are, and let's say if you are exposed to antipsychotics, then most likely you're higher risk of developing tardive dyskinesia. And we see that even the risk increases like 4 or 5 times in comparison, when you're older in comparison when you are younger. So older age is a definite risk factor. Females actually have a higher risk for developing tardive dyskinesia. Just to give you an example, and again, with women, it's just data. I don't think so there is enough scientific research to say why women are more prone to develop tardive dyskinesia than men. But I can tell you that in clinical settings, I see actually more women with tardive dyskinesia than men. So that's another risk factor. African American ethnicity is another risk factor, and it might have to do with the fact that in general, in patients with schizophrenia who are African American, doses of antipsychotics are used at higher amounts. So that might be a potential risk factor. Alcohol or substance use is another factor. So if you have, in addition of, let's say you have schizophrenia, you're taking a medication that might potentially cause tardive dyskinesia. Obviously, if you drink or you use substances, you increase the risk because it has to do with abnormalities on the dopaminergic neurons in the dopaminergic system. And chronic alcohol and substance use can definitely cause alterations of that. Patients with cognitive disturbance, and this is probably related to age too, because as you get older, you might have more cognitive issues, and that's another risk factor. And this one, which is very important, is using high doses of antipsychotics and prolonged use. Even though there have been cases described for tardive dyskinesia with the use of 3 months, as short as 3 months, most cases of tardive dyskinesia develop after a few years of using it, like about the average of 5 years. And then people who has a pre-existing mood disorder, there have been some research data that actually have demonstrated that connection. But people who had prior depression or prior, let's say they have some sort of bipolarity, they can be a higher risk of developing tardive dyskinesia if they are exposed to prolonged antipsychotics. Just very brief about the pathophysiology. Why the people develop tardive dyskinesia? There are three main theories. The one which has been the longest in the literature has been the dopamine hypersensitivity. And just in very simple words, when you get treated with antipsychotics, most of the antipsychotics block the action of dopamine. That's how decrease the symptoms of schizophrenia. Now, chronic dopamine blocking can actually make the brain to create more receptors and makes those neurons to be more sensitive. So when you even have a little amount of dopamine around, those neurons can actually be hypersensitive, particularly in one of the pathways of the brain that has to do with voluntary movements. So that's what creates sort of the involuntary movements after chronic exposure of antipsychotics because of that chronic dopamine blockade and increased number of receptors. There is also a theory on GABA dysregulation. As you know, GABA is sort of like is an inhibitory system in the brain supposed to control things, and if there is this regulation on GABA, sort of the neurons get a little bit out of control and actually can cause this abnormality for movements, particularly in the nigrostriatal system. And then the other theory that has a lot of strength in terms of why some people develop tardive dyskinesia has to do with the free radical production and neurotoxicity in the brain. And this is primarily linked to the use of very old antipsychotics, primarily first generation antipsychotics. And that, there have been studies that show that, chronic use of those create free radicals in the brain and actually damage the neurons. And that can also cause the abnormality on the brain system that causes the abnormal involuntary movements. So this is just in general some of the three main theories why a tardive dyskinesia develops. Now, in terms of the assessment, so what we do when we have a patient, we obviously observe. One of the things that I teach my residents is, always observe the patient, and good psychiatrists are good observers. And, just observe the patient while you're talking to them, look for any abnormality, any abnormal movements. And you can tell just by observation that some patients might have very mild symptoms. Sometimes they don't even realize. And the physician has to be very careful and looking at this. So the physical exam is very important. You don't have to do a thorough neurological exam, but just by observing the patient, and if you see that while they're talking, they're having this, this kinetic movement of the mouth, or if you see that they start doing the shoulder like this, or you see them with the fingers moving in a very abnormal way, and you say, okay, this is, so that's when you start looking at that, and then you start assessing. We have some rating scales that are being validated, and we use it just sort of like, it's not really diagnostic, it's just to sort of like have the degree, how bad the tardive dyskinesia is. One of the most common rating scales that we use is called the abnormal involuntary movement scale. We actually recommend to use that at baseline. So when you have the patient coming to the office the first time, and then every 6 months. So if you go to see your doctor, if you're an antipsychotic, your doctor should perform this rating scale at least every 6 months. There is another scale called the Simpson Dyskinesia scale. It's less used than the AIMS. The AIMS is more widely used. And then we use also the extrapyramidal symptom rating scale, which is a very lengthy one. We use it more in research. It's like a 40-something item scale. It's being used primarily in research. There is a shorter version, but I think the most convenient to use in clinical settings is the abnormal involuntary movement scale, is the AIMS. And also something important to keep in mind, that when you see a patient that you might notice and have some dyskinetic movements, you also want to consider other potential neurological conditions. Again, a good psychiatrist will be able to say, okay, this is tardive dyskinesia versus Parkinson or versus dystonia. I mean, it is not necessarily every abnormal movement, not necessarily is automatically tardive dyskinesia. So it is important to consider also other underlying neurological conditions that can explain the normal movements of your patients. So it's really for the clinician, is, as I say, very important to observe the patient, and they might be the first ones to observe, because sometimes patients are not aware, they might not be aware, because sometimes these movements are very sporadic, no? And you can elicit some of the dyskinetic movements in the office too. There are techniques that we use to elicit the movements when we do the physical exam on a patient. So very important for the clinicians on that. Now, regarding treatment, fortunately, we have 2 FDA-approved medications. One is called valbenazine, and the other one is called deutetrabenazine. And both of them are actually show positive results in reducing the intensity of tardive dyskinesia. I can tell you that I have used it on my patients, and there is a very important reduction of the severity of the tardive dyskinesia when you use these agents. It does not necessarily disappear, but you can go, let's say, if the AIMS was 28, which is a kind of high score, you can reduce that by 50%. Or it can go down to 14 or 12, meaning that, you know, the dyskinetic movements won't be as intense, and it will be less notable, and they will cause less impairment also on the patient functioning. So definitely it's worth it to try if you have a patient with tardive dyskinesia who has moderate or severe symptoms. For those patients who have mild symptoms of tardive dyskinesia, the literature doesn't really show strong evidence, because you might reduce it a little bit, but it might not be worth it to take another pill for something that is very mild. So some patients might want to do it, others might say, no, I don't want to try this because it doesn't bother me much. No, but for those who have severe to moderate intensity of the symptoms, it definitely will be worth it. Now, there is some clinical evidence for other medications, and you probably have read about vitamins. There is vitamin E, vitamin B6, and all these theories come because, as I mentioned earlier, one of the potential pathophysiological mechanisms of tardive dyskinesia is the production of free radicals. So they use vitamins to reduce that propensity. No, however, unfortunately, there have been sporadic case reports that show some improvement, but when they did like large studies, there was not enough evidence to have an approval by the FDA. I have used them with some of my patients, and in combination with other things, and some of them report benefit, others don't. But there is some clinical evidence of some medications. Tetrabenazine has been in the market for quite a few years. It has been used for the treatment of Huntington's chorea, and we use it for tardive dyskinesia back before we had valbenazine and tetrabenazine, and it has actually it works. It's not approved for the treatment of tardive dyskinesia, but it's sort of an off-label use. Clonazepam, which probably some of you might know, is an anxiolytic medication, which works for anxiety. Again, just to reduce the severity of the contraction. Sometimes the patients contract very abruptly with this tardive dyskinesia, so it might actually help to reduce that. Doesn't cure it, but it might reduce a little bit. And then there are a couple of studies on ginkgo biloba that, as you probably heard, that it can help for other conditions. I mean, the evidence is not strong enough to have an approval by the FDA. And then amantadine. Amantadine is a dopamine agonist. It's been used for the treatment of Parkinson's disease, and it has shown some improvement of it. The only problem with amantadine is that it might worsen the symptoms of schizophrenia, for instance, because it's a dopamine agonist. So it might actually worsen that. But it's being used for some cases of tardive dyskinesia. Now, very important to talk about prevention, and I think you guys will be interested in this. As you know, antipsychotics in the last, I would say, 10, 15 years have been used not only for the treatment of schizophrenia or schizoaffective disorder or any other psychotic disorder. They have been used for the treatment of bipolar mania, no? They've been used for the treatment of bipolar depression. They've been used for the treatment of, augmentation for depression. And so there is a wider use of antipsychotics now in mental health. And even though they actually work, what we encourage clinicians is to avoid, let's say we use sometimes antipsychotics for sedation, just the patient can sleep, give them a low dose of that antipsychotic so they will sleep better. Well, that it might help in the short term, but if you keep using it for longer, you might put that patient at risk of developing tardive dyskinesia. So we recommend to avoid the off-label use of antipsychotics if possible. No, let's use it primarily only for the conditions that there is a strong clinical evidence that antipsychotics must be used, like in schizophrenia, schizoaffective disorder, and maybe in some bipolar disorders. But again, if you're gonna use an antipsychotic, let's say sometimes I have patients who come for depression, and you give them an antidepressant, and they partially respond to the antidepressant, and then you add another antidepressant, and the response is still partial. So then you say, okay, let's give them a low dose of antipsychotic, which it might, improve their symptoms. However, just keep in mind that you want to use it for a short period of time, just maybe to get you where you need to be. And then after that, you can taper off antipsychotic and keep the other agents. And that's what we recommend in general, no? To just limit the long-term use of antipsychotics only for the conditions that there is a strong clinical evidence, no? Now, if you're going to use it, use low effective doses, no? The lowest effective dose is better. Don't just over-medicate the patient, because again, the higher the dose, the more risk to develop TD. And then obviously perform the assessments and observe the patient. So if the patient is already on an antipsychotic and is doing well, you always monitor for tardive dyskinesia using either the AIMS or just doing a physical examination. So it's part of the routine evaluation of the psychiatrist. And then obviously choose alternative treatments when antipsychotics are optional, no? So if there is another class of medication that you can use to address the same symptom, instead of using antipsychotic, use a different class. So that's another potential preventive measure that we can use to decrease the risk of disease. There is data that, again, depending on where you look at, but there is people who believe that, even mild cases of tardive dyskinesia can develop even up to 30% of patients exposed to antipsychotics, no? So, I mean, this is something that is more common than you think. All right, and with that, I conclude the presentation. I'm more than happy to answer any questions.
Thank you, Dr. Durand, for such an amazing presentation, and for you for taking your time to educate us about tardive dyskinesia. I know we are gonna go and get some questions. I see Susan raised her hand up, so let me get her. Hello,
Hi.
Susan.
Hi, Susan.
Good evening. So I have a question. If a patient develops mild TD, perhaps blinking or a little bit of head movement, is it an expectation that will increase over time? Or does it usually manifest in some particular symptoms and then just stay at that level?
Great question, Susan. Thank you. So yes, in the majority of the cases, if let's say the dose remains the same, no, the symptoms actually can remain about the same over time. However, if there are changes on the dose of the medicine, let's say increasing the medication or switching to another agent that potentially can cause more movement disorders, then it might actually get worse. When we identify, and something I didn't mention, but we identify, as you say, very mild symptoms of tardive dyskinesia, we start seeing, the emergence of tardive dyskinesia. It's very important to act at that moment and say, okay, well, let's assess the need of either switching to another agent if it's possible, or how can we control it with some medication so we don't necessarily see the worsening over time. But for the most part, if the doses are the same, the movement not necessarily get worse over time if it is the same dose of the medicine. However, I can tell you, nothing is absolute in medicine. There is always variations, and I have seen patients that actually, they have of 14, like 3 years ago, and then 5 years later or 7 years later, the AIMS is a little bit higher, being on the same medicine, but that is not a common. It's not a common. The majority remain at the same intensity, unless you change the medication or the dose. No, yeah.
Thank you.
No problem.
Thank you, Dr. Durand. This is so important, and it's coming from a family member of someone who I believe has tardive dyskinesia. But before I get into that, I want to make sure everyone's questions are answered, but I have one. You mentioned that you can elicit movements with certain techniques. And I'd like to know, what they are. And I say that because my brother was not diagnosed with it, even with many years. And he went to some great doctors in Boston, and it was never brought to my attention. And I'll tell you where I found out about tardive dyskinesia. I was going to a NAMI family-to-family class. Yay, NAMI. When I first moved here, I learned about it, and it still brings tears to my eyes that we didn't know about it as family members. We thought we were doing everything we could. So I'd like to know about the how you elicit those, because the doctors clearly didn't.
Yes, perfect. No, great question. Thank you. So one of the techniques we use, and I can show you with my hands here, is we ask the patient to do this, to touch their fingers. So that elicits the TD. So you ask the patient to do this for about a minute, and you just observe the patient, say, could you please do this with your fingers? And they will do it, and then you elicit the TD, particularly in any part of the body, really, but particularly orofacial. So you will see that they do that. Another technique we use is we ask them to put the hands on both hands on the knees, and we ask them to do the same thing, just to move their fingers like that. The idea is to distract the patient with the movement, and then that's what will elicit the TD. So if it's not that evident, when you start doing this, you will see it more, it's more evident to the clinician. No, so these are some of the techniques that we use. Another technique we use to primarily elicit and to see more clearly, lower extremity tardive dyskinesia is to put the patient on a stool, no? So they can sit on the stool, and making sure that, and you have to obviously ask the patient to take off their shoes and their socks if they're comfortable, and then they can sit on the stool, and the stool has to be high enough so their feet don't touch the floor. And that's how you will see the TD on the feet. It's amazing how you can say, because most patients sit in a chair and their feet are, unless the TD is so bad, you can see they move the feet. But if the TD is very mild, the only way to elicit it is just to have them to sit in a stool high enough so their feet are sort of pending on the air, and you will see how is elicited that way too. So yeah.
Oh, thank you so much, because I think our family members are going to start doing that.
Yes, absolutely. You can definitely do it. Yeah, you can check and see if you notice something abnormal, then bring it up to the attention of the physician. Yes.
Thank you, Dr. Durand. I think Phyllis has a question. Phyllis, go ahead.
Yes.
Yes, my loved one and everything, he has this, and it's on his one right hand. And whenever he's more anxious or stressed, that's whenever I notice it that much more. And he can pretty well control it at times. I never say anything to him and everything, but other people will notice it and everything. And if he sees somebody watching him, he can control it to a point. Yeah.
Oh, very good. You mentioned something very important, is that the anxiety, the stress. Actually, I seen patients when they come to the office, they're very anxious to see the doctor and all that. And sometimes that elicits more of the TD. And the family will say, oh, at home, I don't see him moving. But when he's in the office with you, I see him more with his movements. And definitely anxiety and stress can elicit, and can worsen. Another thing I didn't mention is the majority of patients with tardive dyskinesia don't have the movements when they're sleeping. So if you look at them at night, the movements don't they're not really evident. It's primarily when they're awake.
Is a substitute for snoring, no?
Not really, but yeah, it's amazing, because when we see patients in the hospital, when they're sleeping, they have no movement whatsoever. So.
Thank you, Kathy, for taking the family-to-family class. I teach it.
Great, Phyllis. Yes, I love it. It was amazing.
Thank you, Dr. Durand. I actually had a question even before we started speaker meeting. When we were announcing our speaker meeting, many people asked, and some of them joined today, why 70% of those, we mentioned the number at the beginning, 600,000 individuals with tardive dyskinesia. Why 70% of those haven't been properly diagnosed? You mentioned you have to observe the patient, and sometimes they don't even know. But if that's the case, is that why they don't get that proper diagnosis? Is the assessment not being made as soon as they start taking those antipsychotic medicines? If you can kind of elaborate a little bit more on that, or kind of repeat yourself on that.
Yes, no, great question. So yeah, part of the problem is the late recognition of this condition. As I say, patients sometimes don't necessarily notice it, or they might notice it, but they might say, okay, that's fine. I have actually seen few patients that come to the office and say, Doctor Durand, I have noticed this abnormality on my lip now. Sometimes I move it and I don't know why. They might tell you, some of them, but the majority of them, no, because there is an issue also with, I'm talking more about patients with schizophrenia. They might not necessarily be fully aware. I mean, they're more focused sometimes on other things, like, their own internal thoughts or voices. They don't really see much about their own, body or their own movement. They don't really pay too much attention. So if the family don't pay attention, the patient doesn't recognize it, then it's up to the clinician. It's up to the clinician.
So I know that Attorney Horwich had a question.
We work with a lot of individuals who have developmental disabilities and struggle with mental illness. Is there any research that deals with the overlap between these issues and the TD symptoms, whether it's more pronounced with individuals with developmental delay or less, or?
Yeah, great question. Yes, they're actually more prone. And I can tell you, let me just start by saying that in general, patients with schizophrenia have, even without antipsychotics, that's what people have noticed, they actually have a higher risk of developing abnormal movements. Just that to begin with. And if you expose them to an antipsychotic to treat the illness, definitely they might be more prone to develop. In patients with intellectual disabilities, it's true. They actually, because again, in intellectual disabilities or autistic disorders, there is definitely much more disruption in the brain, and they're definitely more prone to side effects. So I actually see patients with, autism or severe intellectual disabilities who, some of them, unfortunately, you have to put them on antipsychotic to control the behavior, or if they're psychotic or agitation, you need to put them. They're definitely more prone to develop not only tardive dyskinesia, but they can develop Parkinsonian symptoms, they can develop acute dystonia, no? So definitely they're more prone. They're more prone. So it's unfortunate that in some of those cases, we really need to use multiple medications and sometimes high doses of medications to control the behavior. But per se, their brain is more prone to develop any type of abnormal involuntary movement.
Thank you. Is it important to separate out these different types of movement disorders that you've just described? Do they get treated differently? So you have to figure out what is actually going on?
Yes, it's very important because the treatment, for instance, for Parkinsonian type of symptoms is different than the treatment for tardive dyskinesia, no? And it's different for the treatment of acute dystonic reactions. So it's very important, or akathisia, no? Which is the inner feeling of restlessness that patients need to move. So the treatments actually are very different. So it's very important to diagnose them correctly, because you might miss, let's say if you diagnose, I have seen patients who come to the office and say, oh, I've been diagnosed with Parkinson and they're giving me Congentin, which is a medication that's been used for Parkinsonian type. And the patient really has tardive dyskinesia, doesn't have Parkinsonism. So it's very important to differentiate because treatment is different.
Thank you.
You're welcome.
So when a patient is on a medication for tardive dyskinesia, it controls the tardive dyskinesia. Does it retard the process of advancing that TD? And then what happens when they go off the medicine? Does it come back, or has it reversed?
Oh, yes, great question. So what it does is it primarily controls the symptom, because the current two FDA-approved medications for tardive dyskinesia. What they do is they reduce the amount of dopamine in the synaptic cleft between the two neurons. So they reduce the amount of dopamine there. That's how they control it. But if the patient is discontinue the medication, then it will, the symptoms will come back again, and the severity of the TD will be again. It's interesting. In some cases, actually, I've seen that it can be actually worse, and it has to do with the fact that maybe the receptors, because we're not changing the receptors are there and hypersensitive. The only thing you're doing is reducing the amount of dopamine that stimulates the receptor. So if you stop that, the symptoms might come back even with stronger in some cases. So yes, unfortunately it's a condition that doesn't have a cure. It's just the treatment to minimize the severity of the symptoms.
Thank you.
Yeah, you're welcome.
So again, if anyone has a question, we're about to end our amazing speaker meeting. I don't think I'm supposed to say this is my favorite speaker meeting, but I'm going to. It was so informative, and you get to understand. You have, Dr. Durand, a very easy way to kind of understanding some difficult aspect of how everything works, and it made complete sense. And we appreciate it, right? That our community appreciates your time and your expertise. And if anyone doesn't have any more questions, and before we end this speaker meeting, again, thank you, Dr. Durand, for your time. But I wanted to share some of the exciting things that are coming up here at NAMI Miami. We have our walk, Saturday, May 20. Everyone walking together for awareness for mental health. It's a walk for mental health awareness. It's all of our work. It's the Miami Day Walk for Mental Health Awareness, and it's happening on Saturday, May 20th at 8 a.m. at the Lone Depot Park, home of the Marlins. So please register. I'm going to put in the chat how to register, but it's namiwalks.org/Miami. So I'll put that in the chat for you. And then also we have an amazing speaker meeting next Monday, May 8th, from 6 p.m. to 7 p.m. It's going to be about evidence-based practices and trauma intervention. So please join us, and I'll add that link to join us as well. And we also have, again, Mental Health Awareness Month. The more that we're there for our community, and the more we can provide our support groups, educational programs. So we have our QPR, which is our suicide prevention training, on May 9th from 7 p.m. to 8:30 p.m. And I'll make sure that we'll start adding all this to our chat. And we have a family to family coming up in September. So please, I invite you to visit our website, NAMIMiami.org, so you can find out all the programs that we offer. Everything we offer is for free. We have support groups in both English and Spanish for anyone with a mental health condition, and for their family and friends and loved ones and caregivers. We also have educational programs. We do our suicide prevention training at least twice a month, and during mental health awareness, it's more than that. And we invite you to join us, to ask any questions, and to take advantage of those free programs that we offer for our community and our educational programs as well. So if you have any questions also about NAMI, please, we still have a couple more minutes. The chat for our walk to register. As everything that we do in NAMI Miami is completely free. You can create a team as well. And the importance of the walk is that we're all in this together. We are not alone. When we talk about mental health, we all have mental health. So it's important for us to be there for our community, but also to be able to talk to our community, to be able to look around and be together and remind ourselves that we all have mental health. There is hope, there is recovery, and that we offer all these free programs and services for our community. And also we'll have community partners there that will share their resources as well. So please join us Saturday, May 20 at 8 a.m. at the Lone Depot Park. And there's the link in our chat. Well, I'll repeat it again, namiwalks.org/Miami. And then there's the link for our QPR that's coming up. And anything else, please visit our website, namimiami.org. Thank you so much for joining us today, and I hope you have a great evening.
Thank you, Dr. Durand.
Thank you.
Thank you,
Rosa,
Dr. Durand.
Thank you,
Kathy.
everybody. Have a good evening.
Have a good evening.
Bye.
Thank
Thank
you, Dr.
you.
Durand. Good
My
night,
pleasure.
everyone.
Thank you.